welcome to the COPD presentation. So the reason why I wanted to start you guys with chronic bronchitis, then emphysema, then do the COPD is it sort of gives you a background of COPD, because remember we talked about COPD being an umbrella term that includes emphysema, asthma, chronic bronchitis. So there's that triad that's under the COPD umbrella. And that's why you see that Venn diagram there. So when we're looking at the COPD diagnosis, I think it's important to know the individual constituents, like the individual factors that go into it before just talking about it together. Because I could be like, hey, there's COPD, and then it's made up of emphysema and chronic bronchitis, but you have no clue what the emphysema and chronic bronchitis are really composed of, or what really makes chronic bronchitis, and what really makes emphysema. You won't really be able to understand COPD that well unless you sort of look at the three in here. And we will have a separate presentation on asthma as well. But I wanted to at least get you chronic bronchitis and emphysema when we're talking about this. So COPD is a combination of both chronic bronchitis and emphysema. So both chronic bronchitis and emphysema. So that's one of the things that you have to be aware of. It's something that's going to be included in what's going on with this patient. So they have both issues of chronic bronchitis and emphysema. And like I said in the previous emphysema PowerPoint, chronic bronchitis over time, if they continue to get it year after year, remember 3 consecutive months for 2 consecutive years. Now let's say they have that going on for 10 years or 15 years. That's going to cause some destruction and cause emphysematic changes, right? Does that mean their chronic bronchitis goes away? Absolutely not. So what happens over time is this chronic bronchitis leads to emphysema, and now they have both issues going on. That's where we get this whole COPD issue going. So understanding that a person that just has emphysema, let's say you work in a pulmonary function lab and you're doing pulmonary function testing 1 day a week and you work at the hospital 2 days a week, right? So you're in the pulmonary function lab and someone comes in just for baseline pulmonary function testing. If they have the emphysema going on, then you might not see lots of secretions. You might not see a lot of issues there. But if they get exposed to an irritant that causes mucus production, and you might also have a chronic bronchitis going on at the same time with emphysema, that's their COPD. So there's some issues going on there, and that's one of the reasons why these patients are more prone to irritation and inflammation in their airways, and that's why we use inhaled corticosteroids with COPD to reduce that swelling, to reduce that inflammation with this disease process. So they might have episodes where they're just more emphysema, just white mucoid secretions, and other times they might have their chronic bronchitis flare up and they're going to have purulent sputum and they're going to have lots of secretions, and they might need more airway clearance therapy, more than just pursed-lip breathing, right? And so that's one of the things to understand here is they'll have episodes of where they're just sort of clear mucoid with just their baseline emphysema, and then they'll also have chronic bronchitis episodes as well. These patients are very, very prone, COPD patients are very, very prone to pneumonia. And personal experience, so it's anecdotal, that's what you're going to see a lot of your COPD patients if you work in the hospital, if you work in the emergency department. Most of these patients with COPD will come in with a pneumonia because they're very, very prone to infections. Their airway clearance ability is very poor, and their ability to protect their tissue and their ability to get oxygen to their bloodstream are all compromised. And so that makes it very easy for them to get respiratory infections. And that's why educating these patients on hand washing techniques and wearing a mask that's not going to cause them to work hard to breathe, having them know themselves and know their limitations as well as stay active is going to be very important to their quality of life. We don't want them just to stay at home, sit in their lazy boy in fear watching The Price is Right, right? So you're going to have these patients and empower them, be like, hey, just take a couple of steps here or there, and that can make the difference in their quality of life for sure. And that's one of the reasons why I like pulmonary rehab because it helps educate and empower these patients. So with COPD, it's hard to tell, and each individual is going to have some individual idiosyncrasies here. How much contribution to the chronic bronchitis or how much contribution to the emphysema there are. It's hard to really know between the two. Sometimes it's more, are you coughing up lots of sputum, or, you know, hardly like a dry, non-productive cough, right? So if it's productive, it's tons of different colors, that's more of a chronic bronchitis presentation versus an emphysema, right? If it's more mucoid and a dry cough, and it's more dyspnea, baseline dyspnea with exertion, then that's going to be more of the emphysema component. So each individual is going to have their own sort of mix that you will see there, but there's a lot of similarities in how we treat them. They're not identical in how we treat them, but a lot of similarities in general. So it's pretty hard to discern this. We can do this with some pulmonary function testing. Remember, one of the big processes or one of the big PFT tests that we can do to determine if an obstructive disease is emphysema would be the, hopefully you guys can see this, DLCO, right? So that's one of the things that we can do in the pulmonary function lab is a DLCO. Remember, emphysema is the only obstructive disease where the DLCO is going to be low, right? And so that's one of the reasons when we do a complete PFT on a person in the pulmonary function lab, that's one of the big tests that we have to look at is that DLCO. That can help us determine or discern how much of the emphysema component is there. It's not absolute, but it's going to help us sort of discern that a little bit. The big thing with COPD, here's the thing, most of it is preventable, right? And that's the hard part. It's going to be one of those things where we're working, and we've done American Lung Association, not American Thoracic Society. American Lung Association has done a lot of work with trying to educate kids before they would ever get to the age of preteen or teen. So that's why we like to use like third graders sort of in that age range there before they would ever get that social pressure to smoke or anything like that. It's a preventable disease. It's a preventable condition overall, and that's one of the hard parts about this whole process is it is preventable, and the easy way of going about it, or the most effective way currently as of recording this, is still education early on in childhood more than later on. And people have to want to quit, and there's a whole bunch of issues behind smoking cessation, and that's a whole different lecture altogether. I wish I could give you guys a lecture on smoking cessation and one of the more beneficial ways to approach it, but that's not for this class for sure. COPD is a treatable disease. Does that mean we're going to reverse it? Absolutely not. It's going to be treatable, not reversible. There's a big difference. Characterized by airflow limitation, and here's the big thing, right? You should underline, star, highlight. This is not fully reversible. So with asthma, when we talk about asthma and the asthma presentation, asthma is going to be reversible, right? You do a peak flow meter and your flow rates are low. And then we give you a bronchodilator. We wait 10 to 15 minutes for it to kick in. We do another peak flow measurement, and now you went from your yellow zone back to your green zone. That's an asthmatic component. That's reversible. With COPD, it's not fully reversible. We can do a peak flow. We can do a complete PFT on this person. We'll give them a bronchodilator, and it's not going to improve 10 to 15 minutes later. Or if it does improve, it's not going to be a significant improvement. And remember, you have to see at least a 12% change in their FEV1, if you guys remember from diagnostics class, to be considered significant difference. So when we're looking at this, COPD is not fully reversible. All right. Does that mean that we won't treat these patients? Does that mean that we're not going to help them do things like smoking cessation? So the rate of lung degradation, let me draw a graph here. So this is your normal lung degradation as you get older, and then your lung function sort of peaks around the age of 20. Congratulations. So as you get older, your lung function improves, your lung function improves, your lung function improves, right? And then as you get older, right, as alveolar desquamatization happens, so on and so forth, you get exposed to pollutants, things like that, your lungs will start to, right, sort of get older, right? They start to lose their elasticity, they start to have desquamatization, you're losing some of that surface area and tissue. So it's normal for lung function to sort of decline as we get older a little bit, right? That's why we have different expected values for someone that's 20 years old versus someone that's 60 years old. And that's not saying anything against anyone. But here's the thing. When people smoke, their lung degradation is going to go up and they're going to start declining really fast, right? You see that there in that blue where it just goes down really fast, really rapidly. So the rate of degradation can be very, very high. And so here's the thing, we're like, why would we tell them to stop? We know their lung function's bad. We know it's not reversible if they get ultimately COPD where they have both these conditions. Well, here's the thing. If you're looking at this graph at the bottom here, if I tell them to stop here, and let's say they're 30 years old when they decide that they want to stop, instead of the lungs degrading at this same rate, the lungs will then degrade back to the same rate that they would normally. So instead of degrading on that continuing trajectory of extreme degradation, they go back to the normal degradation that they would have without smoking. And hopefully you guys can sort of see that purple line there that I drew across. And so that's one of the reasons why I think it's important to get these people, and a lot of them feel bad, they feel guilty. It's like when you go to the dentist and like, did you floss twice a day, right? It's that guilt, right? And it's not comfortable, and that's one of the reasons why people don't like going there, is they don't want to feel those deep questions. And so it's educate them like, there's hope, right? This means a better quality of life if you quit. This means you'll be able to still do things if you quit now, right? You don't want to continue degrading at this rate. And that's just one small aspect of smoking cessation. But that's a whole separate, like I said, discussion here. But so this is not fully reversible, but there is a lot of benefits to smoking cessation, or just to stopping the continuation of this process and maintaining their lung function as much as possible. So like I said here on this last slide, it's usually progressive. That means as they get older, it'll get worse. And there's a lot of inflammatory response that goes on with this, and that's why we use inhaled corticosteroids with COPD. Now, there are some newer studies, and we'll have to wait and give them time, that also show inhaled corticosteroids are beneficial with asthma as well. So we'll talk about that a little bit, but I want to give those studies more time or more evidence behind it before I start preaching that as of the recording of this lecture. So inflammatory response is going to be the big ones. Usually the inflammatory response is because they inhaled something terrible, and most of the time that terrible thing is cigarette smoke, right? And that's what we're looking at here. So just be aware, the more that they smoke, the worse that their condition gets. And it's not something that we need to be guilting them into. It's more finding the cause of why they have that addiction or why they have that issue going on. So it's not something to start shaming people, right? Don't become the evil dentist. There's a whole different lecture and a lot of different topics on smoking cessation, but educating them that there is hope is at least something you can do, and there are resources available that there is something they can do, like the quit line and things like that. All right, the American Thoracic Society, I love this place. The ATS also does your pulmonary function guidelines as well. And so these are definitions, so I would pay attention to these. They don't go on your chart, your disease chart, but definitions are always free game for me. So chronic bronchitis is diagnosed or based on the major manifestations associated with the disease, like purulent sputum, so on and so forth. Emphysema is based on pathology or anatomic alterations of the lung. With the disorder, and we talked about that, the destruction of the tissue, things like the DLCO would be decreased. Even though chronic bronchitis and emphysema can each develop alone by themselves, right? You can have just chronic bronchitis without emphysema. You can have emphysema without chronic bronchitis. Remember we talked about panlobular, which is the genetic emphysema, right? So they can occur separately, but most often they occur together as one disease complex, and that's why they put it together as COPD, right? Chronic obstructive pulmonary disease, they have obstructive disorder that's chronic, right? And so that's what we're seeing here. And so they group them together because a lot of these patients that have emphysema with chronic bronchitis, they need to sort of understand, and you need to understand, they have both of these disease pathologies at the same time. They're simultaneous with each other most of the time, and so that's why airway clearance therapy, bronchodilators, things like that will all be included in their care, inhaled corticosteroids. Etiology, when we're looking at this, and these are numbers I would not expect you to remember because these will change from year to year. And this is just for your book and just for your mental thought about this, but it's estimated between 10 and 15 million people either have chronic bronchitis or emphysema or a combination, which would be COPD. But most authorities, and this is still true, agree that COPD is underdiagnosed. So why is this? Well, someone that works, I had a neighbor once that had a lot of issues breathing, and they wouldn't go to the doctor. That's not something that they wanted to face. It was that whole mortality thing. They didn't want to be told that they have sort of this issue. And so that's one of the things that you would look at there is like it's underdiagnosed. Some people will have it and not really know that they need to sort of get it taken care of, need to face that they do have it so they can get treatment, they can get educated, they can have a better quality of life, because otherwise they'll continue on their degradation. So it is very undiagnosed or underdiagnosed out there, not because of the lack of adequacy of healthcare, but more because of the patients and their willingness to seek out the truth. All right, risk factors according to the Global Initiative of Lung Disease. Genetic predisposition is going to be one of the big ones here. Alpha-1 antitrypsin protease deficiency. Remember, this one can be, remember there's the ZZ type, and hopefully you've read this in your chapter. Remember, that's assigned reading. But remember, the people, and we talked about this a little bit in the emphysema one, there are people that have a mild form of alpha-1 antitrypsin, a mild form, not true where it's a complete, but a mild form of it. And that means they could smoke for, let's say, 3 to 5 years, and they can develop emphysema very quickly, right? That's a genetic predisposition to it. Where someone that, and I always use George Burns, and maybe you guys don't know who that is anymore, can smoke cigars till they're 99 years old, and they may not have as significant of a disease development overall. And so the genetic predisposition will play a factor. That's why some people can get severe emphysema and severe COPD very early on after they start smoking, right? So there are people that are more prone to lung disease than others, and that's just genetics. That's what you got with it. Age and gender, COPD increases with age overall. That's one of the things that you will see, and we talked about that with that whole curve that we drew over there. So you're more likely to notice the effects the further down on the curve you are when you're looking at this. Conditions that affect normal lung growth. So this would be when we're looking at especially kids that are preemies, they're more likely to develop reactive airways disease, BPD babies, all those things. So that's one of the things that we try to prevent and treat early on. We even have baby PFTs. I don't know if you guys remember that from the very first part of diagnostics class, which we'll see. But we even do PFTs on little tiny babies. And so we put them in this little body box thing, and we put this like little putty around their mouth and their nose, and we can actually do this little vest that squeezes their chest. And so that squeeze will measure their flow rates from that squeeze, and if the flow rates are low, that's a sign they have reactive airways. So we could actually start these babies on inhaled corticosteroids. Like, we're talking about babies. We're starting them on inhaled corticosteroids early on, so we stop the remodeling or the destruction of lung tissue early on. That makes them so that they can possibly have a better quality of life down the road. So things that will affect normal lung growth, like malnutrition, congenital lung defects, things like that. Exposure to particles is going to be one of the biggest things with COPD. These people cannot be out on those bad pollution days, especially if they have severe emphysema or severe COPD. Tobacco smoke is going to be one of the big irritants. I cannot tell you how many times a patient of mine went out to smoke while they're in the hospital with COPD and a pneumonia, would go outside to smoke and then come back in and ask for a breathing treatment. My heavens. So that's one of the things that you would see there. Tobacco smoke will irritate them, and they'll be like, oh, I can breathe better. Well, they can breathe better because they're not coughing up a bunch of mucus, because they've paralyzed the cilia, and now they're not coughing up the mucus. So that's something that they have to look at there. So exposure to particles, including tobacco smoke, some of them feel like they can breathe better afterwards. Realistically, they're actually just sort of suppressing their cough and their mucus production, and then they'll start having a harder time breathing a little bit after that. Occupational dust and chemicals, they got to sort of be aware if they work in a place where there's sawdust and fumes, like diesel fumes, things like that. They got to sort of be protective of that, where they wear masks or they avoid it as much as possible. Indoor air pollution is going to be another thing with them. They need to make sure that they have good quality environment around them. They should not be in a dusty room all day long. So indoor air pollution can be very bad, especially in the winter when all the windows and doors are closed. And nowadays, with all these windows that seal very well, it can be an issue there. So make sure that they don't have a lot of like dust and fumes. And carpet may not be a great thing for some of these patients, and we'll talk about that. But indoor air pollution and outdoor air pollution can play a factor in how effective their breathing is. So that's just something for them to pay attention to as well. All right, so gold. I, of course, thought of gold and the Mighty Ducks when they won the gold, but that's a whole separate thing. Global initial of lung disease. Things that can be risk factors for COPD is their socioeconomic status. This isn't as much studied as I would like to talk about. Your book does talk about this. It's not something I would emphasize for now. Asthma and bronchial hyperreactivity, definitely going to be big risk factors here for these patients. Overall, these patients can also have a reactive component. They can have an asthmatic component to their COPD. So just because someone has chronic bronchitis, and let's say their chronic bronchitis is non-bronchospasm, right? Let's just say they have chronic bronchitis without the bronchospasm, and they have emphysema. Neither of those involve bronchospasm. But let's say we do a PFT on them. Let's say we do a peak flow or bedside spirometry. We do a bedside spirometry, we do a forced vital capacity, and then we wait, give them a neb, wait 10 to 15 minutes after we give them the bronchodilator, and now we see an increase of at least 12% on FEV1. Well, they have a reactive airway component going on, so they have that asthmatic component to their COPD. So is it beneficial for them to get bronchodilators in that case? Yeah, absolutely. So if they have asthma, bronchial reactivity, that can also be factors, because asthma over time, remember, asthma is considered reversible, but over time, can having those severe inflammations and asthmatic reactions cause remodeling of the tissue inside the lungs? Yes, absolutely. And so that can eventually lead to a higher chance of developing COPD or chronic bronchitis, which then can develop to emphysema, which then they go into that triad of COPD. So chronic bronchitis and respiratory infections. Now remember, most chronic bronchitis is caused by respiratory infections. So that's what you're going to see there. You're going to have these patients that have recurrent infections because they're impeding their body's ability to fend off bad things. We talked about that with their cilia being paralyzed with cigarette smoking, right? So if their cilia are paralyzed, their mucocilia escalator isn't working, they get some sort of pathogen that's growing and developing in their lungs, they're going to be more prone to respiratory infections, which means they're going to be more prone to chronic bronchitis, which means they're going to be more prone to emphysema, which means their COPD is going to get worse and worse and worse. So those are all things where we try to avoid as many infections on these patients as possible. Does this mean we give them antibiotics just because? No, they have to actually culture a bacterial issue for it to be something we give them antibiotics for. Tuberculosis also, or tuberculosis can cause a lot of destruction of the respiratory tissue, which can ultimately lead to a higher propensity for COPD. All right, so how do you diagnose COPD? So according to GOLD, the Global Initiative of Lung Disease, key indicators, patients over the age of 40, so that's one of the things we're looking at there. Dyspnea, so this would be either dyspnea on exertion, so DOE, or just dyspnea at baseline. And remember, that's one of the signs of emphysema is that dyspnea on exertion and dyspnea at baseline. Chronic cough, whether it's dry or productive, so that includes both chronic bronchitis and emphysema, right? So they have a chronic cough, they're short of breath, chronic sputum production, right? That's that either where it's white and mucoid or thick and purulent. So that's one of the things you'll be looking at that. Do they have exposure to risk factors? Do they work in a place where they have chronic inhalation irritation, right? Smoke, dust, fumes. One of the things that when I used to do the third grader lectures or the third grader demonstrations with the pig lungs, the smoked pig lungs, the unsmoked pig lungs, and we would always tell the kids, if you can see it or smell it, you should not be breathing it. And so that's something I would hope adults would take to heart, but it's a whole separate issue when you're trying to teach adults those type of things. So are they working in an environment or are they chronically exposed to something that can cause this? And also, do they have a higher propensity? Do they have a family history of lung disease? And that's part of knowing their history. Yeah, my parents had asthma or my parents had emphysema and so on and so forth. Those are all important things. All right, so let's start to look at pulmonary function testing in COPD. And so just like in our other processes that we talked about, one of your big things for obstructive diseases is going to be a vital capacity maneuver. And that's the most common test that's done out of there. So when you're looking at this, so this one's showing and comparing a spirogram of someone with normal lung function where they have a normal FEV1, right? They have a normal FBC, so they have a normal capacity and a normal flow rate when we're looking at this. And when we're looking at COPD, what happens with their flow rates? Well, it's obstructive, right? So there's something going on, whether it's mucus with the chronic bronchitis and inflammation that's causing a restriction of air flowing out of their lungs, right? Or with emphysema, these floppy airways that's restricting gas from flowing out in premature closure. Both of those things are going to cause a low flow rate issues, right? If it's inflammation and mucus, or if it's the floppy airway issue with emphysema. That's what we're looking at here. So they're both obstructive in what you'll see with the pulmonary function test. So that's why both of them lead to hyperinflation of the alveoli and destruction and all that bad stuff. So that's why you see the FEV1 so much lower here. And then even their FVC is going to be a little bit lower. Now this is because, guess what? If their airways are closing or restricting gas flow, closing early, what's going to happen? Are they going to be able to exhale as much gas? Remember, there's this big obstruction that's going on. So that means, are they going to be able to exhale as much gas? No. So even their FVC numbers are going to be lower. Well, does that mean that their capacities are low? No, it doesn't mean their capacity is low. It just means that they're air trapping. And so that's one of the reasons why a body box or some way of looking at their residual volume is going to be important, or their FRC is going to be important. So that's why I'm a big fan of also doing a slow vital capacity in these patients, because if you do a slow sustained exhalation, and you guys have all practiced this, you have less of a chance for that premature closure. Doesn't mean it's not going to negate it altogether, but just less of a chance, and therefore you might be able to get a better look at their volumes than with the forced vital capacity. And if their obstruction's severe, if they have severe emphysema or chronic bronchitis, you may not see a difference in their SVC. You may have to look at something like doing a body box or a nitrogen washout or a helium dilution test. And there, I think they can even do CT scans now that look at total lung capacity and volumes too. All right, so this is a table I took from the book, and this is just sort of giving you that picture of airflow limitation in COPD based upon post-bronchodilator. So here's the situation. We have a person that's been diagnosed with COPD in the hospital. The doctor wants you to do a bedside pre and post. You do a pre-PFT, and then you give them a bronchodilator, and then you give another bedside PFT after the bronchodilator has taken effect. Well, if they have mild, so this is according to GOLD, not ATS, but mild, then their FEV1 is going to be 80% of predicted roughly. Moderate's at 50 to 80% of predicted, and then severe is going to be 50% to 30%. Very severe, less than 30% of predicted. And that's one of the things that they're going to look at is how severe is their COPD. And that's one of the ways that they can actually quantify how severe they are, right? This makes it so it's less objective and more, less subjective and more objective, right? That we have something that quantifies or tells you how bad it is numerically. Now remember, with PFTs, this is a big thing to remember with PFTs. It's all based upon the patient effort, and that's why coaching is so important with PFTs, right? So you could be like, okay, blow, right? If you're quiet and you're not into it, you could be depressed that day, right? It's not one of those things that you can do. And if they have poor effort, yeah, they might be diagnosed with very severe. That's not good, because that means they're going to be on a lot of medicines and a lot of issues. So just be aware, you need to look at their effort too when they're doing these. We want to get the best test we can to get them the most accurate therapy and diagnosis that we can get for them. Combined assessment. When we're looking at this, GOLD recommends combining the assessment. So one of the things that they like to look at is not just the pulmonary function test, but they also like to look at, well, what symptoms are you having? Are you dyspneic 1 day a week, 1 day a year, right? So they like to look at their symptoms. How much are you coughing per week? How frequent do you cough, right? So these are looking at their symptoms frequency and what their symptoms are. The other part is going to be, of course, what we already talked about, pulmonary function testing. So they're going to look at not only their pulmonary function test, but their symptoms on top of it together. They're going to put together the pieces of the puzzle to ultimately look at how bad or how severe their COPD is. So let's say their pulmonary function test is poor. Well, let's say they're at 50% of predicted. And when we look at their symptoms, they're hardly coughing, they get hardly dyspneic, they have a good active life. That might be just more of their ability to either understand the PFT test or to perform the PFT test rather than their actual limitations or their actual severity of COPD. So that's something that's why it's important to include things like symptoms into this. And then when we look at this, we can also see the risk of exacerbations. So ultimately, how high of a risk are you to have your COPD issue when we combine your symptoms with your pulmonary function testing, so they can sort of determine patients' level of activity that would be safe for them, right? And like, hey, if there's an air quality day that's a red air quality day, you're going to be staying inside, so on and so forth. Right, and this is the combined assessment. This is directly from your book, and your book actually tells you how to use this. I will not test you on this, but I sort of want you to be familiar with it in general. This is everything we were saying, and this is just like Desjardins, and this is a Desjardins book. So just like your pulmonary A&P book, it likes to give you graphs that are interesting. So when you're looking at this, if you have a lot of exacerbations per year, so over 2 per year up here, right? Then you're in that sort of high risk. I think if your airflow classifications are high, you're at high risk with less symptoms, or if you're high risk with more symptoms, this means then you're going to have more issues. If you have less than 1 per year, then you're in sort of that low risk, but you do have lots of symptoms. So these are going to ultimately help us to help the doctor to determine the types of therapies, limitations, and all that stuff these patients have. I'm not going to test you on this. I just sort of want you sort of familiar with that concept of they are able to score these patients and help quantify and put together a treatment plan that's not just guessing. It's not just based on a physician or a pulmonologist. It's more calculated than just how a certain physician feels. And that's my whole point here, just for you to look at this. If it looks like Greek to you, that's okay. Like I said, the big point is just to see that we are quantifying. There is ways that we can quantify and help these patients specifically without just taking wild guesses. All right, what else can we use to diagnose COPD besides pulmonary function testing, which, hey, I love that one. So pulmonary function testing, of course, is one of them, lung volumes and diffusing capacity. So these patients will come in on a regular basis, do a complete PFT, and we'll do a DLCO as part of that PFT, right? The DLCO is where they take the slow, deep breath in and hold it for about 10 seconds, and then the shutter will open again and then let them breathe out. That's where they take that one hit of 0.3% carbon monoxide. That's a board question. 0.3% carbon monoxide. And so they'll look at that and see how much of that carbon monoxide actually went into their lungs. If they exhale almost the same amount as they inhaled, then that means their diffusing is low, right? So it's something that we'll look at there. So we'll trend it over time and how significant is their degradation over time. That's why we'll do it on a regular, an annual or semi-annual basis as well. So besides pulmonary function testing and diffusing capacities, so we'll look at their lung volumes and capacities, and flow rates, of course, but DLCO is going to be your big one here. X-rays, chest X-rays can also look at something, how significant your findings are. Now, hopefully this is going to be a PA and a lateral chest X-ray, and so we can sort of see changes over time on their X-ray as well. CT is going to be a lot more valuable for COPD in that we can see the peripheral airways a lot better. As far as that goes, but we'll talk about CTs versus chest X-rays in a later class for sure. But most of the time, they might just go ahead and go with an X-ray over a CT scan when they're looking at this. Oximetry and arterial blood gases. So someone comes into the emergency department, right? Put on your PIMA scrubs mentally and put on your PIMA stethoscope, right, and put yourself into an emergency room mindset. Someone comes in and they're having difficulty breathing, they have a significant history of smoking, they've been coughing up lots of thick purulent sputum. We get a chest X-ray, and this chest X-ray shows lots of infiltrates and all over the place, and they also have a tall column, narrow, skinny heart, right, that's going on here. And so the heart's being squished by the lungs, hyperinflated, and their CP angle, well, their diaphragms are lower, their diaphragms are being pushed down. So we have this air trapping, emphysematic, obstructive X-ray that we're looking at with chronic bronchitis and emphysema all together. So are you going to make this person do a PFT to determine how severe their current condition is? Yeah, no, you're not going to make them do a bedside PFT when they can barely string together 2 or 3 words, right? They have 2 or 3 word dyspnea. it's not going to work to have them do a DLCO. It's not going to work to have them do a bedside PFT if they can barely breathe. And so one of the ways that we can look at this also is to do oximetry and blood gas. So pulse oximetry can also tell us how bad they are from their baseline. Now we can do this when these patients are healthy too. When we do the 9 health fairs, we used to do a pulse ox station. Right, and that's one of the things that we would look at with those patients and trend with them. And a lot of these COPDers have their own little finger pulse oxes they'll bring in, they'll use on themselves, and they know that when their heart rate's high and their saturations are low, that they need a treatment or they need to take a break and they need to catch their breath. Arterial blood gases, we can do these outpatient in the PFT lab as well, and that just sort of trends if they're in a chronic respiratory acidosis, like where it's chronically compensated, or if they're getting into the acute phase. So you got this person here that we were talking about. They come into the ER, COPD, exacerbation, right? Chronic bronchitis with emphysema, and they probably got a pneumonia going on. So when we're looking at this patient, one of the ways we can actually quantify how severe they are is with an arterial blood gas, right? Draw the blood gas. If the blood gas shows a pH of, let's just say 7.35 and a CO2 of 60. Let's just say a PO2 of 57 and a bicarb of 30. So we get this blood gas, right? Now, is this person in a compensated respiratory acidosis? Chronic compensated, right? Are they in a chronic or compensated respiratory acidosis, or are they in an acute respiratory acidosis? Well, this is a chronic respiratory acidosis, right? Because the pH is normal. And so we know that this is significant, but it's not as severe as if we have this person and we draw blood gas and they're 7.22 and their CO2 is 65. Let's just say it's 57, and let's say this is still 30. So then we know that this person here is a lot more severe because their pH has changed. So that blood gas is going to sort of help us quantify in an acute situation their level of severity, and I hope that makes sense to you guys. And so that's one of the reasons why blood gas, arterial blood gas, are going to be a lot of gold standards for helping us to determine level of therapy and so on and so forth, especially in emergency medicine. But like I said, we also do this in the pulmonary function or diagnostic labs as well. Alpha-1 antitrypsin deficiency, protease deficiency screening is something that can be done even at birth. It can be done. It's not part of the normal neonate labs, but this is something that can be done as well. So we can sort of see their level of deficiency, if they do have a deficiency, the level of deficiency, so on and so forth there. Like I said, most of these kids, and this is anecdotal from what I've seen, right? So it's anecdotal, would come in and it's more high liver enzymes that are unexplained that then later on they sort of look at an alpha-1 protease deficiency thing going on with them. So that's where they would run the alpha-1 test. So it's something you wouldn't really know unless you've had it tested on before. Exercise testing. This is a great one. You'll do an advanced diagnostics class, and the first thing you cover in that class, exercise and stress testing. And a lot of it's done for cardiac, but you can also do it for pulmonary as well. And exercise testing includes the 6-minute walk test, and this is on the boards. 6-minute walk test. The 6-minute walk test is going to see how long. We're going to give the patient 6 minutes, and we're going to see how far they can travel in the course of 6 minutes. So let's say they can only do 80 meters in the course of 6 minutes. That's not very long, so that's going to help us sort of quantify how severe their condition is and their level of limitation. That's something that we could also use to help them qualify for pulmonary rehab, things like that. And then let's say we do pulmonary rehab, and when they're sort of through their course of pulmonary rehab, now they can go 130 meters, right? So that's something that can improve their activities of daily living. so on and so forth. But exercise testing, as well as using a pulse ox here, can very much be a useful indicator of their level of COPD. All right, manifestations. I know I'm sort of droning on here. Associated with COPD, usually result from the mechanisms. So the big thing is going to be, hey, there's lots of pollution in the air. I got excessive secretions. I'm wheezing, and I have that air trap, right, that distal airway. So this is sort of what's going on with these patients. They have an issue that's causing them to have their obstructive process. And you're going to see that this is the clinical manifestation. This is sort of what's going on with both of these together. The airway and alveolar weakening is secondary to these chronic excessive secretions and inflammation, and like I said, some of them will have bronchospasm. Remember, bronchospasm can be present in chronic bronchitis as well. Okay, so these are also from your book. So this is when we're looking at chronic bronchitis, and this is the flow chart for chronic bronchitis, as you see here. And when we're looking at this, I don't want to use yellow, maybe red. When we're looking at this is looking at the primary mechanism. This is a flow chart. And flow charts confuse you and make you angry. Do not look at this slide. Move on. So when you're looking at this flow chart, and some people love them, so that's why I like putting them in there for those people that do. A lot of these people with chronic bronchitis, remember, there's lots of mucus issues. So something that moves the airway secretions like CPT, postural drainage, mucolytics, things like that's going to really help clear their secretions and get that airways open up and cleared. But if we cannot, right, what's going on, what's the mechanism of chronic bronchitis? Well, they're shunting, which means they're going to be hypoxic. They're going to be hypoxic, and so that's going to stimulate their chemoreceptors, the peripheral chemoreceptors. The peripheral chemoreceptor says, hey, increase your heart rate, increase your respiratory rate. That's what you see here. Increase all this stuff to help compensate for the hypoxemia. And then to compensate, I'm going to do all these things that will then cause me to hyperventilate. So that's why you'll see that respiratory alkalosis initially, right? And then, well, I can do this for only so long until my respiratory muscles tire out. And then in the severe stage, I'm going to see respiratory failure or fatigue. And also, if it continues to go on, I'll see chronic ventilatory failure with a normal pH, right? That's that whole chronic or compensated respiratory acidosis. So that's sort of what you're looking at here. A lot of these patients will have an increased RAW, so that's because of all the secretions blocking their airways. Lots of air trapping. This where you look at the X-ray, you look at the PFT results. You'll see what they look like at the bedside. So sometimes these little charts here can help you sort of study or see the progression of something like chronic bronchitis, right? So if this makes no sense to you, that's okay. As long as you sort of understand this all together. This is just a way to put the picture of chronic bronchitis. Hey, what is it? What are the mechanisms, right? Is it a shunt-like process? Do they have air trapping? Do they have stimulation of their chemoreceptors? What will happen? What will their ABG be? What will be their vital signs? What will be their PFT? What will their X-ray look like? Right? What will they sound like if I listen to them? Right? What will their auscultation reveal to you? And then what would their ABG look like if they're severe or mild, right? So this is sort of a way to put it all together. And like I said, if this confuses you, then it's okay. As long as you got these down in some way or another, that's okay. As long as you got it down. All right, so this is the same thing for asthma or bronchospasm here. And remember, COPD can include an asthmatic or reactive airway component to it. And then we'll talk more about asthma in the asthma presentation. Big thing here is going to be giving them aerosolized medicine, right? to help with their treatment of the bronchospasm. The other thing that we're going to do with these patients, if they're in a severe state, is going to be give them systemic corticosteroids. So the systemic corticosteroids, and sometimes they may like not to, especially if they have severe diabetes and their blood sugar is issues. You have to do risk versus benefits. So that's something that we'll talk about later on. But the big thing that you'll probably be doing with these patients is giving them lots of aerosolized medicine to help relieve that bronchospasm as much as possible. The other thing that you see with asthma, secretions, right? We'll talk about that. So inflammation, secretions, bronchospasm. Those are all components that go along with it. This is a shunt-like process that causes hypoxemia, that causes stimulation of these receptors, the chemoreceptors, which will then increase your heart rate, your respiratory rate, which then causes hyperventilation, where your pH will be in a respiratory alkalosis, right? So this looks very similar, right? They also have an irritant reflex, whether it's intrinsic or extrinsic. They're going to have a hard time breathing because there's something that's stopping the flow of gas in their lungs. They'll have air trapping. That's why their x-rays are going to show air trapping. Barrel chest can happen with this during an exacerbation. And then ultimately, if they tire out, there'll be an acute respiratory failure. So that's something that you'll see with their blood gas in the late stages. And so this is just a way to sort of snapshot the whole, what is asthma, right? What are the three things going on with it? What's the pathology, air trapping, increased raw, shunting, which then causes their PFTs to look like this, their vital signs to look like this, their x-rays to look like this, right? So that's where you're looking at all these, and that's why I like you guys doing those charts. That'll help you sort of see the differences too. The charts are just a different way to look at these. And then finally, emphysema. Here, big thing, hey, guess what? Pulmonary rehab. What do you know? The big thing with them, pursed lip breathing exercises, training with them, getting them to sort of understand their disease. What's the pathology of the disease? Of course, shunting, stimulation of the receptors, irritation, increased air resistance because these airways are floppy. Lots of air trapping. That means their x-ray is going to look like this. Their bedside assessment is going to look like this. Their vital signs are going to look like this. Their PFTs are going to be obstructive. Early on, they'll be hyperventilating, and then they'll be in failure in these severe stages ultimately, right, with their blood gas. So like I said, these are just sort of summary screens that sort of put the whole thing together. And I hope that if you're a person that likes these and just had some trouble before, that helped clarify these a little bit. You should have these sort of understood, whether you have the flow chart sort of down in your brain or not. This is, like I said, just a quick overview of these three. All right, so pharmacological treatment for COPD. This will change over time as more studies come out. Now there's triple therapy. We're doing LABAs, inhaled corticosteroids, SABAs, so on and so forth. And so this is just sort of a basic idea of what you'll see here. First choice, second choice, third choice for COPD. First choice, short-acting beta agonists, just as needed. So we'll give them an albuterol and be like, if you need it, if you're having trouble breathing, you could have a bronchospasm component, right? That's when they would use that. Second choice, and this is for patients that are not very severe. Letter A. Long-acting anticholinergics, long-acting beta agonists like your LABAs, short-actings are also an option. And then if those aren't working or not something that's the patient can do, then we can go to a methylxanthine, which would be like a theophylline or aminophylline here. Increases drive, increases relieves bronchospasm. It's a bronchodilator. When you get to the worst ones, we're going to be like a patient has severe COPD. They're going to be on inhaled corticosteroids at least. A lot of them will also be in a long-acting betas or anticholinergics as well. Like I said, now there's the triple therapy that's out there, which is very nice for these patients to have one inhaler or one treatment to do instead of 3 separate ones to remember. It's a whole lifesaver. The less things the patient has to do to manage their disease, the more likely they are to be compliant with it. And so that's an important thing, and I think it's incredibly valuable. Like I said, as of me recording this lecture, that's something that we still need a little bit more review on. Second choice, if these aren't working to help control them, then we're going to add something. And finally, when we're looking at these patients, if we still having a lot of issues, then we can still go on to even more significant ones. So this is just sort of the progression of, okay, we've tried the inhaled corticosteroids and that's not working. Let's add something like a long-acting anticholinergic to it, or increase the dosage or the strength of the medicine. That's not working. Maybe we can put these people on something like theophylline. Right, so that's something that you'll look at too. Now here's the thing, it says acetylcysteine here, which is mucomist, which is that sulfur medicine that breaks off disulfide bonds to make the mucus all thin and watery from it being thick and sticky. Be aware, there are some studies out there that show that their pulmonary function values in COPD patients have actually declined with the use of nebulized mucomist or the nebulized acetylcysteine. So be aware of this one here, just something to be in the back of your mind. For people with COPD can actually cause, according to as me recording this, can cause some more negative reactions. So be aware of giving mucomist to someone with COPD. They might have the bronchospasm reaction or degradation of lung function. All right, so they have COPD. How do they manage it? So according to Gold, they look at the clinical data and your assessment and the scoring, which includes, remember, how much airflow limitation they have, their symptoms, right? So they look at all this together, and then all together, this can help us to determine a treatment plan, or you're going to be on this inhaler PRN, or you're going to be on this inhaler every day, right? So that helps us be very calculated in the treatment. So when we're looking at the end of the chapter of this book, it actually gives you some case studies that should help put this all together a little bit better. Okay, so how do we manage it? So we're looking at all these together, right? We're looking at their symptoms and all this other stuff. Beyond the normal day-to-day variations, we're going to look at their medical history, right? Their symptoms of severity, how bad they are when things get worse, and then also their lab tests. And so those are all things that we're going to look at to sort of see how much or how it helps them determine the clinical course that we're going to take with these patients. All right, true or false, the treatment of emphysema and chronic bronchitis is basically the same. Right, this is something I talked about earlier, probably on the very, very first slide. Yes, it's basically the same. So when we're looking at this, we're going to use a lot of similar medications, a lot of similar therapies. Just got to understand there's little idiosyncrasies. If they're not having a lot of sputum, should we add airway clearance therapy to it? If they're having lots of airway secretions, should we add airway clearance to it? So that's something, there's going to be a lot of similarities. There are going to be minute differences here and there. But overall, a lot of the treatments, a lot of the medicines that we'll be using are very, very similar. And so that's why they felt comfortable combining them under the umbrella of COPD. Overall, one of the management techniques that they can use for these patients is called breathing training. And so diaphragmatic breathing, or that bronchiatic yoga breathing, is going to be very, very helpful to these patients. That's where they focus on abdominal breathing. overall, just sort of focus on that deep diaphragmatic, that belly breathing. Put their hands on their belly, like lay down flat if they can. Put their hands on their belly and focus on their belly moving out and in. That deep diaphragmatic breathing. That slow inhalation is going to be more laminar flow rate, which means there's going to be less chaotic or turbulent gas flow in their lungs, which means there's less chance for premature closure and air trapping. So that diaphragmatic breathing helps them there. It also helps massage that whole vagus nerve and decrease their blood pressure, decrease their heart rate, right? And it has them in a more relaxed, less anxiety-induced state, which is very important for these patients, because when you're anxious, what happens with your respiratory rate? It skyrockets, right? So your respiratory rate, I like to write it as frequency, but as your anxiety increases, so does your respiratory rate, which on these patients that need a long time to exhale, is that a good thing? No, that's a bad thing, because that means gas will trap in their lungs. So one of the easiest ways to do that is to do that smell the roses, blow out the candles, that pursed lip breathing, that diaphragmatic breathing, and that should help them resolve that a little bit and help them sort of center themselves. Physical reconditioning is going to be important. This is something that pulmonary rehab is really, really good at. The pulmonary rehab, and they've actually shown, I think it was water therapy, where they had them in the pool doing things. I'd have to go back and look at those studies to confirm that. Is really helping their physical recondition overall, because they're getting stronger overall, and because they're having better use of their body, they're going to have a lot more efficient use of their accessory muscles. That means they're not going to tire out as easily, or not as likely to go into a respiratory acidosis as fast, right? So it's going to help them maintain or compensate a lot better. It will improve their endurance and overall condition. These people will feel healthier. Their activities of daily living will improve, and it makes it easier to perform normal activities, right? They don't feel depressed. And that's one of the huge things with COPD, is their social emotional state. And I know it sort of sounds holistic when I talk about it, but that's a big thing when we're talking about COPD, is a lot of them feel guilt and depression, and it's very, very common. A lot of these patients also will not get very good sleep because they can't breathe very well. They're short of breath, and their brain, when you go into deep sleep, actually gets less oxygen, and so their brain cannot let them go into deep sleep. And deep sleep is when your brain sort of restores and resets, and that's where your hormones get reset and all these other things. And you can look this all up, and I guarantee you it's there. It's very important that these patients have high quality activities of daily living. They have purpose. They enjoy. They know their goals. Depression is a very severe and significant thing in the COPD population, and it's something we need to be aware of as well. We're not, we're respiratory therapists, not therapists, but this is something important for you to understand. So when you have a grumpy COPDer, you sort of understand, hey, there's more to that grump, and that grump has a reason for being there. It doesn't excuse it, but it sort of helps you understand them a little bit better. Nutritional support is going to be big on these patients. You need the right nutrition for the right way of going about them. So I think we talked about this a little bit in pulmonary A&P. When we're looking at nutritional support on these patients, and this is something that you would discuss with dietary or with in pulmonary rehab, they go over this, is going through a higher protein diet with these patients. And then we're also going to do small meals. And then vitamins, of course, we talked about how their electrolytes will be off in COPD, or chronic ventilatory failure. We already talked about that. So the high protein diet, so when you're digesting carbs, what happens to your CO2 levels? Well, your CO2 levels when you're digesting carbs go up. And you also go into, fat production, all these other things. And so your CO2 levels increase exponentially or increase significantly when you're doing carbs. So when they eat a lot of carbs, and you're digesting it, your body's metabolizing it, you're going to have an increase of CO2, which means it would increase your respiratory rate, which on these patients, is this a good thing? It is not. So that's one of the things that would cause them to increase their respiratory rate. It can actually cause them to have a harder time breathing. So having a more high protein diet, it's not for them to look good in their bathing suit at pulmonary rehab. It's for them to actually have a better, easier time to breathe. I hope that makes sense. So that's all about lipolysis versus muscle production. Also, high protein would help their accessory muscles and all that stuff too. But usually a higher protein content with their nutrition should help them as well. Eating small meals. Right? What do you notice? Thanksgiving syndrome is what I used to call it with the neonates. But if you eat a giant meal, do you feel active and you want to go and walk around the block and want to run up and down stairs and run 9 miles on a treadmill? Absolutely not, because your body is trying to digest that big giant meal. What also happens with your gastric distension with a big giant meal, right? Thanksgiving syndrome, think about it, right? So what can your stomach restrict from moving? Your lungs, right? So small meals per day, that's going to help them not only continue having energy throughout the day, but also that's going to help them with their reduction of gastric distension. The other things too is a lot of these patients will be wearing oxygen. When you're wearing oxygen, your olfactory receptors are depressed. Like you can't smell or taste food as much because you can't smell it, right? You can't taste it as much. And so their big issue also is they tend to like oversalt their foods. They tend to not taste foods, or they won't have as much of a drive to eat. So having them eat small meals here and there is a lot more doable and a lot more likely to have them compliant with keeping up their caloric intake, because they're using a lot of calories to breathe, right? So it's more likely to have them in a better situation, having them do more small meals per day as well. Vitamins, we already talked about that. They tend to be low on their electrolytes and things like that because of their chronic ventilatory fatigue or failure. All right, CPT and postural drainage. Postural drainage and percussion is routinely recommended for COPD. No, it's not, right? Not all COPD patients fit this position. Remember, if they have excessive amounts of retained secretions, perfect. That's a great patient for this, especially if they can't get the secretions up on their own. But let's say you have someone that has sort of just this dry, mucoid type secretions, and they're not coughing up much at all. It's just more of the baseline emphysema that's the big issue. Do you want to recommend chest physiotherapy and postural drainage, things that you would use to clean out, right, mucus plugs that are stuck in the airway? No, they don't have that issue. Their issue at this point is just sort of that floppy airway thing going on. And so doing CPT on these patients with floppy airways is not going to be an effective therapy, and it's a waste of time and treatment and all that stuff when you could be focusing on things like teaching them how to do pursed lip breathing and diaphragmatic breathing, things like that. All right, sympathomimetics or adrenergics are beneficial in which of this? All of the above? Just one? Just two? Just three? They reverse bronchospasm. They decrease inflammation. They treat infection. These are supposed to be question marks. I know. So they're only beneficial in reversing bronchospasm. So that's the big thing here. They're beneficial in reversing bronchospasm. That's their primary thing. Now remember what happens to the small airways that are weak and floppy, those non-cartilaginous airways. What are they surrounded by? Smooth muscle, right? And so that's one of the things that gives them structure. So if we bronchodilate, what happens with that smooth muscle? It helps stent open those airways. to make for a larger lumen, so that way they have an easier time exhaling, right? That's going to be one of the important factors here. So even though we're not looking at bronchospasm in this floppy airway issue, one of the things that might actually help them breathe more efficiently and might help relieve their work of breathing is actually a bronchodilator. So just be aware of this, right? Don't be one of those RTs that be like, we're giving albuterol for no reason when someone doesn't have bronchospasm. Well, they may not have bronchospasm, but in a situation where you have floppy airways like you have with emphysema, could it actually help them breathe easier? Yeah, you could make the case for that physiologically. Treating infection, not as much here. That's going to be like your inhaled antibiotics, casein, things like that, that we would use. That would be a whole separate So medicines that we'd use for COPD, some pathomimetics like your albuterols, your Xopanexes, xanthines can be an option as well. A lot of these people would be drinking coffee already, so they'll already be on some sort of caffeine. But they can use theophylline in theory for asthma and or COPD as well. Not first-line treatments anymore, but they're more on the severe side than they might be on a xanthine. Parasympatholytics like your Spirivas, your Atrovens, things like that will help with airway clearance and with backdoor bronchodilation, right? Remember, because they're blocking parasympathetic stimulation in your lungs. Inhaled corticosteroids, going to be important here with inflammation. A lot of them will be on inhaled corticosteroid, BID or QD, depending on which one they're on and the dosage. And then in a severe exacerbation, they might actually give them systemic steroids. So that's something that you would look at in a severe exacerbation. Not something they typically use, especially if the patient is generationally advanced. Systemic corticosteroids are something they try to be weary of with things like osteoporosis and things like that. Antibiotics only if there's evidence of a bacterial pneumonia or a bacterial infection going on. Prolastin is going to be for your alpha-1 antitrypsin protease deficiency patients. And then finally, diuretic, which is something that they call them water pills, but it helps reduce fluid levels inside of the tissues as well as inside the vascular spaces. And this is more if they have heart failure on top of having COPD. And remember, 50% of your patients that have COPD also have congestive heart failure. And then 50% of your congestive heart failure patients also have COPD. So this is one of those issues where you just got to be, I'm bad at this, you got to be aware of this. So if they have a bunch of fluid that's accumulating in their lungs because their left ventricle isn't squeezing out enough, and so a lot of that fluid's sort of backing up in their lungs, what can that do to their COPD? That could make their COPD worse, and that could actually send them into a bronchospasm. So you might have a patient come into the emergency room with congestive heart failure, and the doctor might ask you to give them a nebulizer. Now, is the nebulizer going to stop the pulmonary edema? Is it going to stop the heart failure? No, it's not designed to do that. That's what these guys are for. The diuretics are for. But is it possible they might have shortness of breath, not only to the cardiogenic pulmonary edema, but also to a bronchospasm from the irritation that the extra fluid is causing in their lungs? Is it possible? I would step out on a limb and say absolutely. So would I argue with the doctor for ordering a Duoneb with a person that had heart failure, that had a hard time breathing? Absolutely not, right? Because we know that that irritation of cardiogenic pulmonary edema can cause bronchospasm in some patients. So is it worth it? Yeah, I could say that the risks and benefits in most patients would be worth it. All right, true or false? Antibiotics should be given routinely to COPD patients in order to prevent bacterial infection. I hope you all said false. Yeah, that's not something we would do just to prevent it. That's only something if we know they have it. A lot of times we're prophylactic with antibiotics in certain situations. This is not one of them. Management, the most common cause of exacerbation of COPD is respiratory infection. Like I said back when we first started this presentation, usually you're going to see these patients come in with pneumonia, and that's the most common thing that you'll see them in with. So it's that respiratory infection that's going on, whether it's viral or bacterial, some sort of infection is usually what's going on. So pneumonia is going to be your very, very common reason for a COPD exacerbation. A lot of times, if it gets to this state where they have pneumonia with COPD, they might have issues where they might not come in until they're in respiratory fatigue or failure. So if they come in, we'll draw blood gas, and they're in respiratory fatigue, then we might start them with non-invasive mechanical ventilation. Now, if they're in complete respiratory failure, we might go ahead and put them on mechanical ventilation, but it sort of depends on how severe they are. I think a pH less than 7.25, we're probably going to put them on mechanical ventilation, but or CO2 greater than 55. In theory, you're supposed to be the initiation for mechanical ventilation according to the NBRC hospital. So weaning COPD patients. So when we put them on a BiPAP, or we put them on non-invasive ventilation, or we put them on mechanical ventilation, the thing you need to remember, and this is very tough, especially for new grads to remember, is we need to return their blood gas to their normal blood gas. So what does that mean? Do I want to get this patient to a perfect 7.40, a CO2 of 40, right? Everything that's perfect that we learned what would be the most normal values for the most normal patient in the world? No. You want to return them to their normal blood gas. And so their normal blood gas might be like a 7.36 and a CO2 of 60. Right? So we need to return them to their normals, to their normal baseline state. If we hyperventilate them and we go to wean them, we might not see them. In other words, we go to let them breathe on their own. They might not start breathing at all because their stimulation to breathe has been knocked out as far as that goes. They normally live at a higher CO2 level. So we need that higher CO2 level before their brain says, oh, okay, your normal CO2 level is this, or your normal pH level is this. And so that's when we need to kick in to breathe. So patients, well, a lot of times you'll see them feel dependent on the breathing machine. They feel like they can finally catch their breath. So a lot of times you'll see them become emotional with trying to wean them and get them off the ventilator. It's very sad to sort of see that because they feel like they can breathe so much better with the machine in some cases. And so just be aware of that. They might sort of fight that. So that's something where you're looking at the complications of positive pressure ventilation. And we talked about this in pulmonary AMP, where we're impeding blood flow, we're causing the abnormal change of pressure in the lungs, especially if they have things like blebs and bullae. It can make for a lot of issues. Pulmonary rehab, I'm a big fan of pulmonary rehab, and I'm glad that it's still out there. And you guys should hopefully do a rotation there. And pulmonary rehab is designed to reduce morbidity and improve quality of life. And this is one of the biggest things we can do for these patients, is get them in an empowered state and get them to realize they can still live with COPD. They can still go on their little excursions to Walmart. They can still go and participate. There's so much more life they can live, and it's not as much of a death sentence as a lot of them think it is. And that's why I think pulmonary rehab is vital. It helps them compensate. It helps them see things. It helps them be in a group with other people in this very similar situation. So there's so many benefits to pulmonary rehab, and quality of life is a big thing. And if you don't think quality of life is a big thing, I don't know what to say. So a lot of education here. This includes education from all other therapies, so physical therapy, occupational therapy, respiratory therapy, nutrition, right? All these guys are there, and then they all come together to establish a care plan for that patient, a combined collaborative care plan. This is amazing and incredibly important for them to have an improved quality of life. The idea here is to reduce their symptoms and complications. Maybe we get them exercising to the point where their 6-minute walk test is improved and now they can go out for walks around town and stuff like that. And the other thing that's looking at is to hopefully help reduce hospital admissions overall. And that's why there was a big advantage to when the universal healthcare thing was going on. I'm not taking a political standpoint here, but a lot of them preventative medicine like pulmonary rehab started to look more important because there was a thing called COPD recidivism, where people would come to the hospital, they would get treated, they would get discharged home, and then they would come back within a couple weeks. Well, the whole discussion there was the hospital did not do a good enough job at treating them, and that's why they're back. And so the insurance would then bill the hospital or make the hospital eat the cost of that patient's care. Because they did not do a good job previously. So one of the things that hospitals were starting to do to reduce COPD recidivism was pulmonary rehab. Hey, you're going to pulmonary rehab, you're going to participate, you're going to have that way to do it, so it helps stop you from coming back for hospital readmissions. What's the prognosis? Usually it's varying in degrees, depends on person to person. Some will have very slow progression, some will not. The big indicator here that we'll look at in the PFT lab is the FEV1 and FEV1%. And that actually can approve someone for disability as well for government assistance and parking spaces and things like that. You might be doing some PFTs for this, right, to look and see what their level of disability is. All right, and then this is just something I want you to look at. So these are the mild to very severe stages. Long-term oxygen therapy is a big thing if there's chronic ventilatory failure. So if you do a blood gas on this patient baseline and it shows chronic or compensated respiratory acidosis, then long-term oxygen therapy is a big thing. Also, if they have areas of Bleb's bullae, things like that, they can also consider some surgical treatments. So this is just looking at severity stages and how bad they are by using their bedside spirometry, right? Chronic ventilatory failure, FEV1 is 30% are predicted, FEV1 to FVC is at 70%. Then we're going to have an issue where they have a very severe form of COPD, so they're going to need oxygen therapy, inhaled steroids, or systemic steroids, depending on that, how they are personally, right? Individuals will vary there. LABAs, SABAs, pulmonary rehab, aggressively work to reduce risk factors, make sure they get their pneumonia shot, make sure they get their flu shot, and then we're going to give them SABAs, the short actings, and so on. So this is just something you sort of see that we have a treatment plan for the level of severity that they have with bedside spirometry. We're not just guessing at this, like there's an actual plan. So just understand that we do quantify these things. We do have a plan and a process to the craziness that is sort of COPD.